Okay, get started. Welcome back to the Wayland Library. Thank you for coming out tonight. We are excited to have Dr. Andrew Eyre here to talk to us about simulation in medical education. Dr. Eyre grew up in Wayland and obtained his MD from the University of Vermont. He completed his training through a Harvard residency at both Brigham and Women's and Mass General hospitals. We need to mute the computer because, there we go. Okay. Today, he's not only an emergency physician, he's also an award-winning medical educator, researcher, and writer who has held a number of different leadership roles at Brigham and Harvard Medical. Most importantly for this evening, Dr. Eyre serves as the medical director for the Stratus Center for Medical Simulation, a world-renowned simulation center at Brigham and Women's. Thank you so much to Dr. Eyre for being here tonight. Couple housekeeping notes. First, we're recording this session for broadcast on Waycam, our local cable access station, and you'll find it on the library's YouTube page as well, so you can share with your friends. We are recording Dr. Eyre and his slides and the back of your heads. Second, Dr. Eyre will speak for about 35 minutes. We didn't talk about this. Well, he'll speak, and then we'll have a Q&A session at the end. And for those of you attending on Zoom, please put your questions into the chat box at any time, and I will read them out loud. And so now I will get out of the way and hand it over to Dr. Eyre.
Okay. All right. So thank you so much for having me. First of all, thank you to Mr. Engler for inviting me, to the library for having me. This is kind of a special audience, at least the folks in the room, because all of you pretty much have known me since before I was born. So it's really exciting to be here. I have way more content to present tonight than I will possibly get through. That's okay. That's by design. We'll get through what we get through, and then we'll kind of go from there. So I want to start, well, first of all, start by wishing my father a belated happy birthday. Happy birthday. So I want to start by doing something, this is going to seem a little funny, but called kind of the thumb meter. I want to get a sense of how familiar people are with what medical simulation is. So if this is like thumbs up, I know everything there is to know. And this is down low. And I'm just going to remind people who are at home to mute themselves, please. Thanks. So if this is like, I know everything there is to know, this is, I've never heard of it before, I have no idea what you do, like, show me on your thumb scale where you are. Interesting. So this is great. So this is going to be actually fun, and I'm hoping just to give people an introduction into what is very much an emerging and actually a really cool area of medicine that frankly didn't exist about 20 or 25 years ago in the way that it does now. So a couple of just things to go over first. I have no financial disclosures. I'm going to talk about a number of different products. I don't own stock in any of them. I wish I did, but there we go. There are going to be a couple pictures. Some things may seem a little bit gory. It's all simulated. It's all fake. Nothing's real. Nothing's actual blood. But if you're going to pass out, we'll go with it. It's fine. So I've got lots of equipment on my car. Don't worry about it. So I want to just start by having everyone kind of think to themselves a little bit about a couple questions, just to set the context of what we're talking about. So you all come from different backgrounds, different medical experiences, different kind of interactions with the healthcare system. And my guess is you've had some good experiences and some bad experiences. So take a couple minutes and think to yourself, have you ever had a complication from a procedure or an operation? Or have you ever worried that your provider who was taking care of you or a loved one didn't have enough experience, either in the condition that they were treating, that specific type of illness, or that particular procedure? Or they said, you know, I want to do something a little bit different. We've only done a couple of these before, but I think this is the right time for you. Or kind of flipping things a little bit, have you ever felt like you had an interaction with doctor, nurse, physician assistant, physical therapist, whatever, where their communication wasn't quite as good as it could have been? They could have broken the news a little bit better. They could have explained something in a little bit better term that you would have understood. Have you ever wanted to give your doctor, your nurse, whatever, some feedback that maybe they didn't do things the best that they could have, or maybe this is a better way to talk to a patient, but you didn't really feel like you could because, they were the one taking care of you, and if you anger them, then they're the ones potentially doing terrible things to you. So just keep that in the back of your mind as we talk to all this stuff, because medical simulation really is a solution to a lot of those questions and a lot of those concerns. And so we'll talk about this from different angles, but really this is an area of medicine that is designed to address a whole host of issues and problems. So a couple more thought questions. Just thinking through kind of some analogies. Who would you want to lead your favorite sports team coming down till the final minutes of a close game? Would you want this person? He's reading the book, he's learned the plays, like everything's great, seems to have a lovely jawline. But does he actually know how to play football? Maybe he could take a test or a multiple choice exam to show that he knows the football plays and the rules. But do you really want him or her leading the team? Or do you want this person who's actually playing the game, maybe not quite the same level, but maybe he's like gone through high school, he played for his high school team, and that was great. Or do you want this guy? So Tom Brady was notorious not only for his abilities, obviously, but even after he was well known for his dedication to practice. He would watch film. He would do play after play after play after play and practice until it was perfect, and then he'd keep doing it again to stay up to snuff. Maybe football isn't your thing, so let's go to tennis. So I'm just dealing with this. Sweet. So same idea in tennis. Championship match. Do you want someone who has a proven record and has been able to show time after time after time that they're able to win, they have the mental mindset, they've been in those tough situations before? Or do you want someone who's maybe young, youthful, has like the newer racket or whatever you want to do, and who are you going to trust? So moving away from sports, who would you trust to fly you on your next plane? Do you want this guy? Like, yeah, he graduated school. He probably passed the exam. But the question is, like, in a normal, straightforward flight, like, that's awesome. You need competence. Great. That's wonderful. But if things are going to go south, who else might you want? So for those of you who don't recognize it, this is Sully Sullenberger. And he was the pilot during the infamous landing on the Hudson. It's not a coincidence that he taught aviation safety. He had reviewed crash scenes. He was an instructor for all sorts of kind of very advanced classes. And he also trained in simulators so very often. And he practiced exactly these kind of landings so that when kind of the unexpected and the rarest of the rare happened, it was essentially muscle memory. He had practiced this procedure time after time. And even though this is something that really no one has done before successfully, he was able to do it because that's how he trained. So now moving to medicine, because we've talked about how people in sports practice a lot to perfection. We talked about the aviation industry, which is really where a lot of simulation came from, that oil industries, other high-risk areas, but now medicine. So you are due to have some procedure, some new treatment. Do you want this person on the left, the young one, who is reading the book, has gone to the classes, or do you want the people who are training as a team? They go to the operating room together, they practice together, they train for the rare outcomes, the rare complications, and they have actually talked about exactly what they're going to do in any scenario. So that's really what we're talking about here. But kind of the interesting thing in medicine where so much has changed, medical education really hasn't changed much in many years. It's starting to, but the same model of you do 2 years of classroom education, then 2 years of clinical rotations, then you do a residency, and then you graduate. No one has really been saying, well, how do we know that you're ready to graduate medical school? Or how do we know that you're ready to finish your residency and start seeing patients? Like, it seems a little bit weird that we just say at the end of 3, 4, 5, whatever years, you're ready to go and be on your own. So more and more, there's this movement to say, it's not just about time, but show us that you know how to do the hip replacement, that you know how to do the biopsy, that you know how to put a breathing tube in. Prove it. And prove it to us before you're doing it on patients. So for centuries and centuries, there was this edict of see one, do one, teach one, which isn't actually all that far from the truth, that if some new procedure came out or some new operation came out, you'd watch someone do it, then it would be your turn to try. But it was kind of understood that, like, yeah, you're still learning, like, you're not an expert at this. So if you make a couple mistakes, you hit an artery that you're not supposed to, like, that's what happens. Like, it's part of the process. And, like, we laugh, but there's some truth to it. And even for me, there are many procedures I learned using simulation, but there are still procedures that I learned by, yeah, I watched a video on this, but, like, time to try it. And then you teach someone else to do it. And this is actually pretty common. So what we're going to be talking about is that this kind of mantra of see one, do one, teach one really should not be how it's done anymore. And for the most part, it's not. So both the practice of medicine, the education of medicine, but also patient expectations and expectations for patient safety really have changed. As patients, we don't want our providers practicing on us anymore. We don't accept complications just because someone hasn't done a procedure as often as a different doctor or nurse. So really things are changing. So we're going to talk about a couple things. We're going to talk about what simulation is. We're going to talk about why simulation. I've got a couple slides on kind of how this all fits into educational theory from an education perspective. And then really what I want to spend most of our time on is actually talking about the different types of simulation. What are the tools? And I'll be quick to say that this is not about the tools or the stuff. The tools and the stuff are cool, but unless you know how to use them, it doesn't really matter. So just like if someone said, here's this new cool software called Zoom, like enjoy your 2 years of pandemic communication, it doesn't matter if you don't know how to use it. If someone hands you some other educational tool, you need to learn how to use it to actually make effect. So it's not just about the stuff. It's about how do you fit that into an educational model. And that's really where my job comes in, because like anyone can buy the stuff, but a lot of what I do is think about how to put it into curriculum, see how we can create different programs for people. So we'll talk about those things and a few other items as we have time for. Okay, so first and foremost, we spent a couple minutes talking about like the context of all this and what's going on in medical education, but what is simulation? So the like one-liner is simulation is pretend. It's imagination, it's acting, it's fake. But to get a little more complicated, this is simulation. You got this very expensive mannequin. We'll talk about that shortly. This is simulation. Two folks practicing surgical procedures on very high-tech computerized equipment that give you haptic feedback so you actually feel if you hit something you're not supposed to. This is also simulation. These are my kids. And because they're my kids, they have no chance at a realistic life of normalcy. But this is my, at the time, 2.5-year-old daughter pretty much putting in a breathing tube in her stuffed animal better than most people because she's watched me do it. This is my now 2-year-old practicing defibrillation, once again, better than some of my residents. So there is an element of watching, but there's also an element of like, I can let them practice these things because there are tools and devices to let them practice in a safe way. Like, I'm not going to let her put the pads on me and defibrillate me, but I can bring her into a simulation center and let her practice and play without any danger to me or anyone else. So that's her 3rd birthday party. So the official definition that's out there is that medical simulation is a technique that creates a situation or environment to allow persons to experience a representation of a real event for the purpose of practice, learning, evaluation, testing, or to gain understanding of systems or human actions. And it's a great definition in that it's very much all-encompassing, but it's hugely vague. Like, you read that and say, that's cool, but what does that mean? So it's a big definition, but basically, as I said, sim is an educational tool, and the tool has to be implemented appropriately. It's got a lot of benefits, but it also has a lot of drawbacks, and I'm the first to say that simulation is not real. It's not designed to take the place of patient care. What it's designed to do is to a place that you can practice patient care safely, minimizing some of those risks, And also, once you have provided patient care, you can keep those skills up. And we'll talk a little bit about that, but it's kind of this untold truth that a lot of physicians will learn all these skills, and you're probably at your peak for some of these skills coming out of residency, and then you don't do them for a little while. And just like all of us, if we don't practice something, our skills go away. If you don't play tennis for a year, your serve is not going to be as good as it was when you were playing every day. That's just how it works, and unfortunately, it's the same truth for medicine. So sim is another way that people can keep some of those skills up when maybe they don't have the opportunities clinically to do so. So a slightly different definition, that is from me, is that sim is an educational tool that allows learners of all levels to learn and or practice both the cognitive, i.e. the thinking part of medicine, as well as the technical skills in a controlled, reproducible, and safe environment without the risks of actual patient care. And it's risks to the patient, but it's also risks to the provider. So as someone who has made mistakes and hurt people, it doesn't feel good as a learner to make those mistakes. So simulation lets me make mistakes. I'm encouraged to make mistakes, and I encourage my students to make mistakes, but I want them to make it in the simulation center where we can reset. We can say, pause, that wasn't the right choice, let's do it again. And then they can learn from that. So it's about providing a safe place where they're encouraged to try things, improve, take risks, knowing that those risks don't have to carry forward to patient harm. All right. So a couple more boring slides than the fun stuff. Okay, so as far as the benefits, we talked about it's a great opportunity for learning and teaching, but it also lets me kind of ensure fairness when I'm looking at my students and teaching. Because it's in a simulation center, I can control exactly what they're saying and what they're seeing. So if I want to see how well they can manage a heart attack patient, if I go to the hospital, I'm trying to assess those same things. One person may be 50, one person may be 80. One person may be on lots of medicines, one person may have had a heart attack before. It's not consistent. So in the simulation center, I can control everything exactly as I want it. I can make sure the vital signs are exactly the same. If they give a certain medication, I can make sure that the response is exactly the same. And that lets me be fair to everyone. It also lets me test them if I so desire. And our Zoom probably went out. But that's fine. So it's an amazingly versatile tool in that I can create cases or procedures of just about anything that's out there. And we'll talk about that a little bit more later. But I can simulate someone with rabies. I can simulate someone with a heart attack. I can simulate someone with a stroke. I can have a pediatric patient or an older patient. Like, I can do just about anything I want, and there are lots of different ways to do that. But the drawbacks. So like I said, it's not real. I am very much a person that when I'm practicing medicine, I like to think I take into account how many people are into the room, the body language of the people, the sights, the smells, who else is around that can be hearing me. You can't replicate all of that in simulation. So it's not designed to be fully encompassing, and you just need to realize that and accept it. But you can do a lot. All right. So because of that, you don't want to use it to teach everything, but it can be used to teach a lot. So a couple theory slides. So most of the time when we're using simulation, we are talking about teaching adults. And adults are different than teaching kids. I can make my kids learn whatever I want. Sometimes it's good stuff, sometimes it's bad stuff. Trying to get adults to learn is different. For adults to learn, you have to make connections and make it relevant to them. Adults aren't going to waste their time on things that are not worth learning. That's just a simple fact. So what simulation does is it lets us take what would otherwise be a little bit esoteric material, things that don't necessarily make sense to them. It gives them a context so that they actually understand what they're learning, why they're learning it, and why it's important. If you show them that learning cardiac physiology is important to a heart attack patient, they will pay a hell of a lot more attention to it than if you just say, look at this formula or learn about blood vessels. Making those connections matter. So you want to make it relevant. You want to make sure that they're learning at a time when they're actually free to learn. If you're rushing around the hospital trying to get all sorts of stuff done, you're stressed, you're tired, That's not the best space to be learning. But if I bring them down to a separate educational space, give them protected time to learn, then they're actually in the headspace to take in the information that I'm giving. So it just has a little bit of different implications for how we're teaching. And this is a slide that talks about kind of adult education in a different way. It's basically a pyramid that talks about how deeply people understand information. So down at the bottom, which is the lowest level, people remember stuff. You can get most people to remember facts. It's memorization. I can get people to read about medications. I can get people to regurgitate back what a normal blood value is or what a normal sodium is. But that doesn't mean they understand it. Next level up is, do you understand what that information is, what it means? And then the next level up is, can you apply it? So what we're ultimately trying to do with simulation is take it from you learned something in a textbook, you remembered a fact, you can regurgitate it back, to can you actually apply it to a case? So my guess is you've all had experiences where you've encountered people who know the fact, but actually applying it to what's in front of them, that common sense or the actual practical knowledge is not quite there. So we're trying to take people from a very superficial but perhaps impressive amount of memorization to actually can you do the stuff that you're supposed to do? Can you use the knowledge in a meaningful way? All right. So at the end of the day, what we're trying to do, and take this as your summary of the educational theory part, is we're trying to create this interactive experiential learning by providing learners with an experience that basically serves as a memory, or what I call kind of an experiential scaffold. So if I asked you to think of the times that you learned something, or the most valuable memory that you had, something that's the most forward in your heads, you're probably not going to tell me something you read in a book. You're probably going to tell me about some potentially traumatic experience you had, some amazing thing like when you had a child, when you got married, when you made a mistake and someone got hurt. You're going to tell me something emotional that has valence to it. So what we're trying to do is take people away from yes, you had this thing in the book or you learned this in the classroom, to let's give you an experience. And then after that experience, we'll actually talk about it. We will have a conversation and a learning discussion right then and there, so that people have had this experience of, let's say, taking care of a heart attack patient or taking care of someone who is bleeding out in front of them. You get people jazzed up a little bit. You get people a little bit emotionally invested, and then you can put some information on top of that. The learning really happens after the scenario, after this memory is created. But as we're about to see, you can create some pretty impressive memories as well as some really cool hands-on experiences. So now I want to kind of transition into talking about the types of simulation. We talked a little bit about the theory, and yeah, you go to school and you learn how to create curriculum. This is the toys, this is the stuff, and this is the stuff that you probably haven't seen that much of before. And it's pretty cool. All right, so the first type of simulators that are out there are called task trainers or procedure trainers. So these are a couple of pretty common examples. This is to put in a special type of IV called central line, to put in a breathing tube, to do procedures on a baby. This is for doing open heart surgery, to do IVs, to put chest tubes in. So these task trainers are models that are designed to teach a specific or a small number of usually related skills. You can buy them. You can buy one for just about any procedure you can imagine, or you can make them. They can be expensive, but they're designed to be reused for the most part. And you can learn, you can practice, or you can test them. So like I said, you can very easily say, listen, before you want to put IVs in for the pre-op patients in the hospital, you have to go to the sim center, show us that you can do a perfect IV start to finish without any mistakes. That's an option. We have similar programs for putting those big central lines in the hospital that come with big infection risks. So before anyone in our hospital can do it, they have to come down to the simulation center, soup to nuts, show us that they know how to do a procedure sterilely. It's not even about doing the procedure, it's about can you maintain sterility so that people don't get costly and potentially deadly infections. So you can set up these programs not just to have about learning, but also for testing. So a couple examples. Like I said, we make these trainers for just about anything and everything. So this is to practice physical exam skills. This one happens to be for doing eye exams, but you can do it for learning cardiac exam or belly exam or musculoskeletal exam. This is a task trainer to practice knee replacements. So, for example, there's a program in Canada, where the residents in the orthopedic residency have to show that they can do an entire joint replacement procedure before they even make it to see the patients. They say, show me that you can do all the steps, all the equipment, and you can talk through what you're doing before we go to the operating room. Because then the part that's actually new is doing it on the human that bleeds, that has actual realistic tissues, but at least you know the steps. So that's their model. Not everyone's there yet. This is a colostomy trainer, just to show that there are lots and lots of trainers out there. A couple more examples. We have trainers to practice laparoscopic surgery, so same idea. Before you show me that you can take out a gallbladder laparoscopically through these little tiny holes, show me that you can tie a knot. Show me that you can tie things in an appropriate way that they won't leak. Show me that you can cut things out without damaging the other tissue. Show that you know how to move the camera in a way that's safe and gets optimal views. So nationally, there's a curriculum that you have to be able to do these skills before you are certified to do laparoscopic surgery. There are lots of computerized task trainers. This one is for practicing robotic surgery. This is for colonoscopies and endoscopies and bronchoscopies. This one is another surgical computerized simulator to practice, that happens to be a gallbladder. And most of these things, what they do is they take you from the very small, discrete tasks of hand-eye coordination, how to use the equipment, all the way up through doing full-scale simulated operations. They give you scores, they tell you if you're dropping things, they tell you if you could have better efficiency of movement. It's pretty high-tech stuff, and in that way, you get a sense of, how am I doing? Am I improving? What else should I be doing before I start to go provide patient care? And it's not to say that you can't go back and forth. Like, you can be in the operating room, you can do these procedures, then you can go back and practice, and you can get even better. And if you had a tough time in the operating room and the surgeon who was supervising said, listen, your knots just aren't that good, then you go back and practice. So it's a nice, versatile system. This is another trainer. This is one that we had one in my simulation center. It died, so we're going to get a new one, hopefully. But this is an endovascular simulator. So anything procedurally through small holes with wires. So cardiac catheterizations, going to get blood clots out from people who've had strokes, putting in tubes into the kidney from the side. This is a list of all the things that they can do. People who have got constricted blood vessels in the groins. And all this basically is using x-rays and fluoroscopy to guide wires and catheters going through the body up to the tiniest things in the brain all the way down to the toes. And it's amazing technology in the first place, but it's even more amazing that we can do this in a full body simulator that has built-in x-rays, that has built-in ultrasound, and the coolest thing is that I can create pathology on here. This is not just about healthy patient one time, like have fun. I can give this patient really bad coronary artery disease. I can give them a really bad aortic problem. I can give them a stroke. And this particular one lets me also take the images from actual patients, take their CAT scan, take their MRI, and upload it into the system. So I can go to my resident, fellow, student attending and say, we're going to do this case tomorrow. Here's the patient's actual x-ray. Here's their actual CAT scan. Let's practice on that patient's anatomy so that we know what we're going to do tomorrow. And it's super cool. And so even if it's going to be the most senior surgeon doing the procedure, this is a way that you can also get junior people involved doing the same stuff until they're at that level to do it safely. So for the people who've had cardiac ablations, for the people who've had aortic repairs, for the people with strokes, like this is a machine that lets you practice all those things. So it's neurology, it's cardiology, it's the trauma service, it's all of interventional radiology, and it's pretty cool. So just to put this in context, because we're talking about practicing stuff and all those things, a couple of very quick stories, and I'm keeping track of time. So I actually kind of didn't like simulation when I started doing it, and I started doing this way back when I was working on an ambulance. Like I said, I liked interacting with people. I liked the kind of variation that comes with the sights and sounds and all that stuff. But when I was working on the ambulance, we had a small simulator to practice putting those breathing tubes in. So when I was bored, I would practice a couple times a day. Everything's fine, went off to medical school, and the first time I intubated a live patient, it was pure muscle memory. It was the smoothest of smooth procedures because I'd practiced it hundreds and hundreds of times. I wasn't trying to figure out the equipment. I wasn't trying to figure out how to put the scope in the person's mouth. It just was normal. Just like practicing tennis, just like hitting hundreds and hundreds of backhands, and then you go do it at a different court. So a second story, and this one's more recent. So this wasn't my patient, and that's an important caveat because whatever happened to him wasn't my fault. But about a year ago, a patient came into one of our hospitals, and the short of it is that he ended up getting diagnosed with what's called pericardial tamponade. So his heart was surrounded by fluid, and essentially his heart was trying to pump in a closed system with a lot of fluid, and it gets to the point that it can't open and fill with blood, and if your heart can't push blood, you die. So he lost pulses in the bay and was dead. He did not have a pulse, he was dead. And so the way to fix that in the hospital I was in is to stick a needle basically into that sac around the heart and draw fluid out. So this is a procedure that is pretty rare. We have enough technology that it's rare that people get to the point that they lose pulses and die from this thing. But it happened. And so I'd never done this procedure before, but I'd practiced it a lot. I'd taught it a lot. And so I ended up doing this procedure that I'd never done before. While the needle was around his heart, sucking out fluid, he got pulses back. He's doing great. Like, it's a procedure that I've never done before. But it felt really natural because I'd practiced it plenty of times, and I can actually think back to the exact session in the simulation center where I learned how to do the exact same steps that day. So just putting those things into context, it matters. And you have these kind of epiphany moments every once in a while of where something you actually learned really sets you up, because otherwise, like, you're doing something you've never seen before, maybe haven't practiced before, and it's different. So a couple more task trainers, and these are some of the higher end things that didn't go over well. Are you still sharing? Or you're videoing me?
I'm videoing you.
Okay.
You don't really have your slides.
Perfect.
We'll have it on the recording.
Great. Sorry about that. So now we get to review. It's perfect. Yeah, it's perfect. All right, so now let's try this. So this is a video that kind of talks about some high-end simulation stuff, and hopefully you guys can hear that.
I had this one patient who came in who was shot in the chest. There's all kinds of red flags going off in your mind that the heart could definitely be injured, and sure enough, his blood pressure was dropping. So it was clear that he was really on the verge of dying. That's where you need to get in there rapidly and try and regain that blood pressure back before the brain cells start to die. It's about 4 minutes to happen in a way that's irreversible. The atrium, we were able to put a clamp on and oversew in the trauma bay, and then the one on the surface of the heart, we gained control just with our finger. Good. So that's the end of the scenario. The way you did it was perfect. You got it all the way across. Now, we're using this kind of simulator with just the right amount of being lifelike. It's a perfect setup for simulation So residents aren't put into situations where they're practicing for the first time on a patient. So I'd rather you just, probably the most realistic part of the whole model, I think, is the heart. The motion of the heart, whether it gives, whether it doesn't give, whether it's moist or dry, these are all the components of the human body that make it more realistic.
Right. Mark DeMoya had developed a prototype, and then he wanted to get a higher degree of realism, and so he brought...
So for the sake of time, I'm going to skip ahead. But basically, this is a company that was in the Hollywood movie industry doing special effects for movies that you all have known and loved, or known. And they went into simulation. So they're building these extremely realistic models with the stuff that they learned in the film special effects industry, now making these models that are designed to appear as lifelike as possible. So that model, in the recording, they're talking about how to use it for trauma if someone's been shot or stabbed, but they also make it so you can practice a coronary artery bypass, open heart surgery on a beating heart. You can stop the heart if you want, but it's actually pumping, it's actually moving blood around. So you can practice valve repairs and everything else on a very realistic model. This is another one that I'll show a brief clip from, hopefully. So this doesn't have sound, but this is designed to be a simulator that looks at if someone got shot or stabbed in the belly or has kind of a catastrophic surgical problem in their abdomen, that you open them up pretty much from top to bottom. You look at all their intestines. You try to find what the problem is. This is all fake. And you may talk to surgeons in the room who say this is ridiculous, because I have. It's actually pretty realistic in the grand scheme of things. It's pretty good. So in this one, they're finding that there's bleeding coming from the vena cava, the major vein in the body. They're practicing the steps to fix it. And like we said before, it doesn't have to be perfect. It has to be good enough that you're going through the steps of the procedure. You know what you would do. You can practice those things so that if it happens in real life, at least it wasn't 10 or 15 years ago that you last did this. It was the other day in practice. All right. So I said, though, that they make these procedural trainers for just about anything. There are a couple that they don't make, and sometimes I make them because that's fun, and they don't have to be this fancy. You can make things out of paper towel rolls and tissue paper and still talk about the same steps. It's not about the stuff. It's about the practice of doing it and the cognitive theory behind why we're doing it. But the stuff is cool. Let's call it what it is. So the other thing, like we talked about with the endovascular simulators, what if you want something to be a little bit more specific to the patient in front of you? So this is part of a clip about Boston Children's Hospital. They obviously have a lot more people coming in with unique congenital abnormalities that people have not seen before. They're the people where they have the 1 in 10 pathology in the globe, or 1 in 10 people around the world that have their particular disease, illness, pathology. So they're often doing procedures that they haven't been able to practice before. So because of that, they have come up with a pretty effective 3D printing program. And what they'll talk about in this clip is taking the images from a specific patient, turning it into a model, and practicing the operation on that particular model. So it's not just like, we're going to go buy a thing to practice a specific operation. I'm actually creating a model that we can practice for your particular procedure.
Hemispherectomy is probably the most challenging operation, and it's used in fairly rare cases.
So this was a young boy who had seizures and then needed to basically split his brain apart.
It involves actually disconnecting one whole half of the brain from the rest of the brain and from everything on the other side. What's really made a big difference is being able to actually get a model of the brain that we can practice the surgery on before doing the surgery.
I'll never forget when he said, we're going to do something with your son that we've never done with anybody before. And I was like, what? He said, we have this 3D printing machine, and I can make an actual replica of his brain before the surgery.
3D printing has been used to make guns, dresses, cars, and prosthetics. But using new 3D technology, BCH can simulate the conditions of even the most difficult of surgeries. This technology allows them to take CT and MRI scans of a patient's brain and turn them into 3D printed models, which surgeons can practice before going into the
Was actually able to perform this operation in its entirety on this child the night before surgery and actually show it to the parents and say, this is what we're going to be doing.
It was so amazing to know that the surgeon was going to go in and actually do the surgery on this replica before he was going to touch my baby.
Until now, medical simulations have been limited to simple training exercises like CPR or intubation. Gabriel's surgery marks a breakthrough in medical simulation.
Nobody wants to be the first person to get a hemispherectomy from a particular surgeon ever, really. So why would you ever want to have your first operation be on a real patient? And I think that's what we're seeing with the simulator movement. 3D.
All right. So we've spent a little bit of time talking about procedural trainers. Once again, those models that are designed to teach or practice a specific set of procedures or surgical cases. So that's one bucket of simulation, and a very popular one. It's what I like the most, frankly. But I want to switch gears a little bit to talk about what's called mannequin or case-based simulation. So this is a different modality, a different kind of skill set, different types of things that you're trying to teach. So basically in this category, you have robotic mannequins that are remotely controlled by a computer, and there's a faculty member that's controlling everything. Controlling the heart rate, controlling what the blood pressure is doing, controlling what their eyes are doing, controlling what breath sounds, what lung sounds they have. And I'll show you momentarily all the bells and whistles that these mannequins can do. So someone is kind of playing puppeteer in the background. They can play the voice of the patient. They can have mannequins that are really, really young to really, really old, all skin colors. And usually what we're doing, you can perform procedures on these, but really this type of simulation is about the thinking part. This is, can you make the diagnosis? Can you talk about what would happen if you give the medicine? So these are the things that you can't practice on patients from a mental perspective of what happens if I give the wrong medication? What happens if I have a patient who's having a stroke? How do I assess them quickly, give the right therapy? Holy moly, their blood pressure just dropped. Let's give blood. Now what do we do? Who do I call for help? Who else do I need on my team? Let's go to x-ray. Wait, we can't get an x-ray, so what are we going to do? So this is a way that we can integrate all that stuff essentially into a pretend case that lets them practice the entire encounter. So when we're creating these cases, we try to think about what are we trying to teach? And then we create a script, just like a storyboard in advertising or a script in a play, of what the patient's going to say. If they do this, here's what happens to their vital signs. If they do this, here's what happens. Here's what we want them to do, but if they do something else, here's what we're going to do about it. So it's this game of trying to anticipate all their moves and choreograph it so that we know how everything will play out. But here are the mannequins that we're using. So these are computers. They're plastic, they're chips, they're wires. They cost probably about $60,000, but what you're about to see is the list of all the things they can do. They can pee, they can sweat, they can cry, their pupils respond to light. You can have it programmed so that, let's say you want to give someone a certain dose of epinephrine, it can calculate the volume that you're administering, it will know the concentration of the medicine, and it can respond appropriately. So if you give too much, it will make the heart rate too fast. If you don't give enough, it won't fix the problem. You can program all these things, and it's pretty amazing. So let's take a peek. So this is just a list of all the stuff you can do, a bunch of procedures. And depending on how real you want it, you can have it have pulses in different places. You can actually have it measure a real blood pressure, so not just I'm telling the computer what I want, it's actually measuring a real blood pressure. It will actually measure your oxygen level. It will actually measure the carbon dioxide you're breathing out to show if you put a breathing tube in the right place. It's just a question of what bells and whistles you want. So you can act IV fluids in, you can actually put a catheter in and have pee come out. I mean, if you want to. You can defibrillate it, you can do CPR, you can do all sorts of stuff. This part's weird, I give you that. So these are the reactive pupils, so just like an aperture, the pupils open and close. So if you want to say the patient had a drug overdose and they have got really tiny pupils, there you go. You want to say that the patient's in shock and they're sweating, there you go. And I'm going to skip ahead for the purposes of time. But these are a couple other mannequins just to show the extremes. This is a neonatal baby. This is a more geriatric patient. You go to these conferences and you see these like random things. You're like, I'm not sure if that's a person who's supposed to be alive and isn't, or if that's a simulator, and it's just a little confusing. And I've been mistaken before. So the way this plays out, like I said, we can create all these cases, and we're really just creating a script. So we have essentially a one-way mirror, just like it was a psychology lab, where we can look in, we can call into the room, we can change the vital signs, we can give them the x-rays or the CAT scans. But we are doing everything on the outside, and we'll let the case run for as long as we think it needs to, usually 10 or 15 minutes. And then, like I said at the beginning, it's not about learning in the case. It's about giving them an experience and a memory that then we talk about after. So this is an example of one of our faculty members. He did a stroke case, and then they talk about how they did. What went well, what didn't go well. If you were at a different hospital and you didn't have a neurologist, how would you treat things differently? So it's much more about talking through things and learning after they've had an experience to work on. But you can also test things. If you want to talk about how would you sedate someone for their surgery, we can test that here. We have scenarios where we give someone a terrible systemic infection and we see, can you treat them? We give them a GI bleed and say, can you treat them? And these things can be not that real, or they can be super real. So I'm going to play you a video of what's kind of the realest of the real that we get at our Sim Center. And so we've been talking a lot about students and trainees. This is a course that we ran for our attending surgeons and anesthesiologists. So the malpractice company that serves all of the Harvard hospitals basically said, you get sued, you pay millions and millions of dollars. So maybe we should try to prevent some of those lawsuits. So they donated money to a bunch of different programs to run these training sessions that basically let us practice intraoperative emergencies. So just like you practice an engine going out on an airplane, let's practice what happens if the patient's bleeding. Let's practice what happens if the patient's airway closes. So what you're going to see is this is all the same scenario. We tell the surgeons that you're taking a tumor out of whatever body part. If you're a brain surgeon, it's a brain tumor. If you're an orthopedic surgeon, it's a thigh tumor, and so on. The tumor's down here. The surgeons and the OR nurses are up here. This is the anesthesia team. This is the patient's vital signs. And so what we do is we bring them in, have them work together, and once again, it's not about what happens in the room. It's about talking about it afterwards and having essentially a mini therapy session of like, here's what I saw, here's what you did, I can play you the video, so let's talk about what you did well, how could you do it better? How can we practice the things that we're supposed to do? So this is a quick clip of that, hopefully.
All right, then I guess we're good to go. We'll get started.
and it jumps around a little bit just to truncate things a little bit. So that's the tumor. But we give them live suction, we give them live cautery devices to cut through tissue. And then we can give them things here that ethically you can't do in the hospital. I can't ethically go to the hospital and say, we're going to let this patient bleed out until they're just about that close to death, and then you get to fix it. But we can do that here. And we can see if they follow their protocols. So as they start to get a little stressed and they get into it, then we can say, do you actually remember to follow the right procedures? So in this scenario, we give them the wrong patient's blood. It's not the right type for the patient. And we say, can you make sure that even when you're scared, nervous, upset, that you follow the protocols and make sure that it's for the right patient, that it's the right type, and you're not going to cause a problem. And so now in the scenario, the patient's bleeding, their blood pressure is down, they're starting to get blood ready to give the patient. They're starting to call for help, which is nice. They're calling a vascular surgeon in. And I'm going to skip ahead, but what we see in this is you actually have the anesthesiologist saying, stop messing around, the blood pressure's low, we need to fix it, don't do anything. And surgeons being surgeons, they keep clipping stuff and tying things off, and then you have the anesthesiologist saying, no, seriously, stop doing anything, we just put pressure on it, let us get blood into the patient. And they're like, yeah, okay, cool. And then they keep doing stuff. So what you have is an opportunity to then actually get the two groups together and show them a clip and say, so we had this really cool moment of Dr. whatever saying this, Dr. whatever saying, yes, I hear you, and then you didn't do it. So tell me what you're thinking. Like, what happened there, and how can we fix it? So it's a really cool opportunity. So I want to move now to another bucket. We've talked about these procedure trainers. We've talked about these mannequins that can do stuff. But we said that the mannequins are not real. And if you're trying to teach people how to communicate better, you need people to realistically communicate. So there's this other bucket of simulation called standardized patient simulation. So essentially, this is using live people. And so if you're looking to communicate, this is about as good as it gets. So we use typically professional actors or other trained professionals to play the role of the patient. Just like an actor for a play, they get a script. They know what they're supposed to answer certain questions, like where does it hurt, what medical problems do you have, what medicines do you take. They know where they're supposed to say, yes, that hurts, or if you tap on the reflexes, they say, actually, my knee really doesn't do that, or they'll show you a correct reflex. So it's a really popular tool to teach basic history and physical skills at the medical school level, but then for anything communication, breaking bad news, talking about an end-of-life diagnosis, talking about hospice, talking about someone who maybe is being abused, talking about someone who doesn't kind of know as a family member what they want to do for their sick relative. All of those types of things are perfect for this because unlike a real conversation where if you're having that with a family member or a patient and you say something wrong and the whole relationship goes down the toilet, this is a trained professional actor and you say, stop, pause, time out. Let's go back, let's do it again, and maybe this time you don't say, like, when your family member croaks tomorrow, here's what, like, you can reset and do it again. And you can actually get feedback from the patient. So it's an amazing way to actually work on communication skills, which when we talked at the beginning, like, I think all of us have had times where the communication wasn't quite there. So it's not a perfect exam, but it's really good. And a lot of places not only do the actors do some of the grading, but more importantly, they give a lot of the feedback about, as the patient, I felt that you weren't listening to my needs, or as the patient, I thought you were really warm and receptive, but you talked too much, you asked too many questions. So it can be really helpful. So those are some of the examples that we run. So we have something about how our psychiatry nurses can react to agitated patients. We've done things on how do you do an appropriate gun safety assessment. So if someone says, yeah, I'm having thoughts of hurting myself, and by the way, I've got a revolver in the household, like how do you talk through those things without jumbling your words the first many times that you do it? So this is a quick clip about that.
Standardized patient is an individual
are here to give feedback to our students on communication, professionalism, and on the physical exam. They are really here to meet the gap between the classroom learning and real life.
As a standardized patient, I pretty much am what's really going to be considered an actor patient. I am given a script, and you read over the script and just get familiar with what your symptoms are going to be.
Once we have been trained on the script, we actually interact with the student.
And we answer all the questions the training doctor needs answered, and just try to be as authentic as possible.
Once we do an encounter with the student, then after that we would evaluate the student. And once we finish the evaluation, we actually give them feedback on the encounter.
It's giving them an opportunity to be a doctor before they actually have to be one.
The students tell us that this
So I will tell you that every medical school in the United States participates in programs like this. They may not have their own patients, but they use groups from other centers because that's one of the portions of a credentialing exam that you have to take to graduate medical school. But we talked about kind of communicating with patients, and that's fine, and usually they're nice, but like, how do you practice with difficult patients? So you can also do that here. So this is an example of a mental health program dealing with most likely a schizophrenic patient. And how do you de-escalate things?
So we're running through a really exciting program that we're working with in collaboration from our colleagues at the modality to really be able to align with some of the things that we're trying to do around education with the Medical Psychiatry Alliance initiative. And it's really exciting because it's a partnership between CAMH and Sick Kids and the university and Truly Health Partners, all of our MPA Alliance partners. And what we're really doing is looking at clinical scenarios to help a variety of health professionals learn more about how to take care of patients with coexisting medical and mental health issues. And we're doing it in a very fun way. We're doing it using real-life scenarios and settings in different clinical contexts. So, I mean, is that real-life experience?
So it's not real, but it's pretty good. And when you're trying to figure out how to deal with this, it's far nicer to be doing it in a safe environment where someone says, scene over, and the patient's like, oh, cool, you did a great job, rather than that whole thing. So there's one more kind of bucket that I want to talk about, and this is one that is still very much up and coming, and then we'll stop and just chat for a little bit. But more and more as technology allows, computer and mixed reality, so virtual reality and what's called augmented reality, are becoming viable tools and not just gimmicks. So as with all things computer, someone has to program it. So because it's programmed, you don't have the same flexibility as, for example, with the cases where I can say, I don't really like what the student did, or they did something I wasn't expecting, so I'm going to do this. I'm going to use my medical knowledge, my judgment to change things in that direction. Because it's programmed, it kind of has to follow the algorithm. But it does some cool stuff. And you can build in grading. You can build in assessments. And so it's not as good for communication because it's a computer for the most part. But to go through kind of those basic steps, to go through some of the thinking parts, it's pretty good. And more, it's becoming a viable option, less expensive, better quality, and it's a lot of fun, actually. So these are a couple of examples. This is something the American Heart Association puts out to practice. Instead of going to do your CPR class in person for 8 or 16 hours, you can do this program online. Similarly, though, it can get frustrating where if you say, well, I was going to ask the patient how they were feeling, then I was going to put the defibrillator pads on, the computer's like, no, you did that the wrong way. Fine. This is one to practice the steps of oral surgery. They have things for all sorts of different surgical subspecialties. This is an actual very cool program that lets you think through more of the diagnosis and thought process. So you ask the questions to the patient, then you prioritize kind of what you think is going on. As you get information back, you change what you think is going on and what treatments. So virtual reality, like I said, is also becoming much more interesting. So It's almost there. It's getting really cool. It's not quite there to the point that everyone's using it, but a lot of people are. We have folks in the center that I work in that their research is kind of in creating these virtual reality scenarios. And we have a couple of simulators that actually use this that I'm super excited about. And just compare what you're about to see to looking at anatomy in a book or seeing a picture on the wall. It's just so different and so immersive. So this is going to be a quick video about learning ultrasound. So we have this simulator where trying to picture the black and white grayscale ultrasound pictures, like for those of you who've ever had an ultrasound or sonogram, trying to say, I see squiggles, how the hell is that my baby? Like trying to put that together with actual anatomy and physiology, and once again, I can change all this. I can give the patient a heart attack. I can give them that fluid around their heart. I can give them an extra large aorta or whatever. And then you put these 3D goggles on, so everything's in front of you. The anatomy rises up. You can walk around it. You can put your head inside it. So let's see it.
Healthcare is the global training partner of choice to improve.
It's actually there. As a teacher, I can see what they're all looking at. And that's something that we think has real power.
It's actually opening up our...
All right. So I will quickly just say that we've talked about lots of different things. Putting it all together in a simulation center, we put a lot of these different modalities together. So we have classrooms where we can film a case or stream it to another place and then talk about it. We have places to do procedure training. We have a simulated operating room that you saw in one of those other videos that's the exact same specification, size, shape, equipment as the actual Brigham Women's operating rooms. We have these case rooms where you can have simultaneous patient encounters going on. We can take the walls down and have it be one big room. We have all sorts of flexibility. We have all these kind of bells and whistles to practice these different tests. We happen to do research, and I kind of left that out of the talk for this purpose, but we do research on emergencies in space. So we have a life-size mock-up of the International Space Station Medical Bay. So there's all these cool things to do, but I will leave it there. And happy to talk about stuff, take questions. If you're in Zoom land and want to put stuff in the chat, we can go from there.
Great.
Yes.
Andrew, when you're using the simulators, like doing surgery, and you're messing up all the inside, does it just snap back, or do you have to go put it together? What happens after you've ruined it?
Yeah, so the question was about, with some of these simulators, after you've done the procedures, after you've messed around, what happens? Some of them have replacements that you have to buy, and kind of, so for example, if you want to buy one to practice taking out a gallbladder, you've messed it up, you then have to buy a new insert for that. You don't have to buy the whole frame again, just the gallbladder insert part. Some of them do just kind of fold back together. A lot of things, like with needle-based procedures, they'll reseal again because they're silicone or rubber-based.
Do you have to have it be special, if you replace that gallbladder, do you have to know how to do it, to put it back in?
So there's actually a job now that is called a simulation specialist, where you learn how to do all these things.
Okay.
But yeah, there are manuals, there are all sorts of other things to figure out how to do it. It's not particularly hard. There's YouTube or courses. Yeah.
Obviously, the teaching hospitals have these simulation rooms. Do the smaller hospitals have anything comparable, or obviously not as expensive, but do they have?
Yeah, so the question was about kind of, a lot of these exist at medical schools and academic hospitals. Do they have them at some of the smaller hospitals? It depends. Most of them will have some components. It's a question of how much. So for example, the emergency department may have one model to practice intubation or defibrillation on, but they're not going to have all this other stuff. Newton Wellesley has a small simulation center, for example, but it's about thinking about who their learners are. They are not going to have all the attendings in the hospital. They don't have as many residents, so they don't need as much stuff. At Brigham and Women's, we have people come from all over the world and the country to our center for programs. We bring elementary school students in, so we have some of the bells and whistles that you don't need to have other places. So the answer is it depends, but most big hospitals have something. The smaller hospitals, it's kind of hit or miss, because just from a financial perspective, do you rent it instead? And you can rent a lot of these things for a course, or do you build the infrastructure to have one at your hospital? Yeah?
Andrew, these pieces of equipment are extremely sophisticated.
Yes.
They don't just appear and work.
Correct.
You've got to go through all kinds of beta tests and everything else, and somebody's got to be expert enough to be able to predict all the kinds of things that the doctor might see.
Yeah.
Do you have a special department that participates in that, or do you just wait for that to show up in the marketplace?
So the question was about kind of how the engineers pair with clinicians to know this stuff. So a lot of the companies will get people to pair with, so clinicians. Other times clinicians will create a model and then sell it to industry, but so some of them are a little bit more straightforward. You can get people with less experience to guide them, like for example, making a model to do wound care, or a model to do like putting a Foley catheter is not as complicated as some of these more sophisticated things. So some of these are formed by surgeons. There are people who have decided to go from the education world, and they pair with a computer programmer, they pair with an anatomy person, and they get these teams together. So for example, at the place I work, I will have conversations with some of these vendors about their simulators. They'll ask sites to beta test. So for one of these early ultrasounds, we were a beta testing site to give them feedback on it. They'll talk with physicians and all sorts of different departments to get input, and also collaborate. Yeah?
So a question from the Zoom, is any of this technology used during peer review sessions?
So it's a great question. So I'm going to assume that whoever's asking that is asking peer review as in like morbidity and mortality, something went wrong. So it's a whole area that I didn't get into for the sake of time. But whenever there's a problem that comes up, or you have to decide why a mistake happened, this is a really awesome way to do it, rather than just talk through the case and saying at 12:02 the patient did this, at 12:04 nurse whatever did that. you can bring a simulator in front, or you can link into the simulation center and basically reenact the case and pause and say, now what would you do here? Or here's what happened, here's why it happened, here's where the mistake went wrong. So it's not as common as using it for education, but it's a really nice option. And then just on that quality improvement lens, like for anyone who's ever built a house and they realize that like, we put the door in, that's great, but holy crap, it means I can't open the kitchen like stove door. Using these for the logistics and the operations planning part has become really valuable. So the Brigham just doubled or tripled the size of their emergency department. And we did simulations with these mannequins of, well, now that the place is 3 times as big, like where do we store the emergency supplies? It takes 3 times longer to get the emergency equipment. So like, where are we gonna plan this? When Ebola was happening, how do we plan out the shortest path from ambulance to room? What's gonna happen with the blood tests? Like how are we actually gonna get them from the room to the lab without people getting contaminated? So all those things, talking about how do you evacuate a hospital if there's a flood or a fire, that's where simulation comes into all these extraneous stuff that we didn't even touch on tonight. Yeah.
Andrew, how receptive are experienced physicians in going for retraining or using the simulation to stay abreast of things?
Yeah, so the question was about, we obviously talked a lot about junior students, people who've kind of grown up a little more with this technology. How about people who didn't necessarily grow up with this and are maybe a little bit more senior? It's mixed. I would say, so part of what I do is I consult in other countries about using this modality. And so we're probably about 20 years ahead or 10 years ahead in the United States compared to most other places. So we're kind of seeing other countries where you have kind of the old guard surgeons saying, well, that's not how I learned, I'm not going to do that, that's crap. People here, I think, are starting to see the benefits. So, for example, I gave a tour today to an orthopedic surgeon who really wants his trainees to do this. When we bring people down for those other sessions there, they get buy-in. As far as kind of maintenance and certification, people are interested because, like we said, for the last 20, 30 years of the practice, they've been applying knowledge rather than taking multiple choice tests. So in the anesthesia world, instead of taking a 2-day computer test or multiple choice test, they can come down, have a simulated patient in front of them, show that they know how to be an anesthesiologist instead of kind of esoteric book knowledge. So it's changing. More and more groups are going to use this for...
But they don't have to.
As of now, they don't have to. It's an option.
Last question, because we gotta let you go home. How much of your time are you doing in this versus
Clinical.
doing the rest of your day job?
So in my role, I'm the medical director for the center. We have education specialists who just work with faculty to create these programs. So if my dad comes down to teach a program on urology, he's not there to set up the equipment, he doesn't know how to put it together, he doesn't need to know how to write the curriculum, he's there to talk about the medicine. So we have people who set everything up, set the program up, help create the learning objectives. The physicians, PAs, nurses, whatever, who are instructors come down and set it up. So we have a whole team that does all that. But to answer your question, I'm half-time clinical right now and half-time leading the
It's a
center.
big part of your job now.
Yeah.
More and more?
That will probably be pretty constant. It depends on all the other kind of extraneous stuff of what happens with it.
But you like both.
Yeah, so I love being a clinician. I love the patient care. But as I'm sure you've all seen, healthcare is tough right now, and especially in emergency medicine, like the circumstances are tough. So this job lets me balance those. I really like the teaching part. I really like the hands-on part. I've always kind of been a tinkerer, so I love making my own kind of low-cost models to teach things that, like, it's cool to buy something for a lot of money, but it's also kind of fun to make something cheap that lets you get the same educational experience across. But I love taking care of patients, but they both feed on each other. So the stuff I see in the hospital, the things that go wrong in the clinical space, that informs how can you make it better in the educational realm.
But there's excitement in the young people who are coming.
Yeah, it's fun.
Yeah.
It's fun, and it's great to be able to teach them. It's great to be able to have them understand that there's a better way of learning.
And they're all receptive, I mean, it's, yeah.
They love it. They're not sitting in a classroom listening to lectures.
Fantastic.
Yeah.
Thank you so much.
Absolutely. Thank you for having me.